Morning, morning everyone. I've got a bit of a cold, so I'm wrapped up this morning. Morning out. Good morning. How you doing? We're back on YouTube because Facebook are blocking third-party apps broadcasting live to the platform. So back to YouTube, which is actually better for my YouTube viewing figures. So I think I may just stay on YouTube because I've never had any problems with it at all. Cool. So we had a good session last week, looking at a few more in. Good morning, Claire and Tristan. Good morning, and Becky. Good morning. Got some new ones and some usuals as well. So last week some good questions came out of last week. There was quite a bit because we're starting to explore pathology a little bit more with each of the regions that we look at, and the muscle tendon pathology for the hip and gluteal hamstring region is really common. And so that I'm going to finish that session off this morning, and then we're going to have a look at the nerves around the hip and the pelvis region as well. So we've got nerves that supply all the muscles at the front, the inside, and the back. So hopefully it will start to all then tie together. Fingers crossed. Okay, so let's have a look where we were. So this is where we were up to. And we were talking about tendon balance. I'm not going to go in too much detail because we did this last week. But if you remember, I forgot to do the intro last week, and it's because I was prepping something, and then I never showed it. So I'm definitely going to show it this week, and it's to do with this slide. So like everything in the body, we've got our body wants a balance of things, and we were talking about tendon balance last week, and how if you do too much activity, too much load through a tendon, and you do it too quickly, so there's a spike in the training load, then that can degrade the tendon. It responds negatively. And the tendon environment becomes catabolic, so it starts degrading itself basically. So here we've got a foot, like this is the so normal, so load here, normal or just above normal load. So we get a positive adaptation is here, and then if you continue to push it, but the preceding weeks or months haven't led up to that point, so you haven't adequately prepared, then there'll be a failure to adapt, and there'll be a net catabolic environment for that tendon. So, which is obviously not very good. But then also there's this stress deprivation as well, which kind of makes people, I don't know, a bit confused really, because they rest because that's what they got told to do by some medical professionals, and then it actually makes it worse. And they're like, well, I didn't do anything, especially if they're quite active, if they're a runner or a cyclist. They're used to being active, and then they're told to rest. That the deprivation of load can have a catabolic effect as well. So we need a balance between the two, and we need to monitor that. And we were talking about that last week on our exercise therapist course. So that's quite timely, those of you that are with us this morning. So it's very similar to this. So this was the image that I was prepping. I think it was Lars Avamarie that posted it again, and there's always this thing, and it's a kind of myth that's perpetuated that running is bad for your knees, and you shouldn't run, especially past a certain age. But what's bad is not doing any running and doing too much. Okay, so it's exactly the same. All right, so they had a look at recreational runners compared to non-runners compared to competitive, and they looked at the incidence of knee and hip arthritis. And if you have a look, so we've got recreational running is not only good for your overall health, but also benefits your knees and hips. which goes against what loads of people think. Absolute loads of people think that. Just 3.5% of these runners develop hip or knee arthritis. A sedentary lifestyle, so not running at all or competing as an elite runner, increases the risk of hip or knee arthritis by 10.2 and 13.3% respectively. Okay, and that was from that paper. Just move me out of the way, so if you want to, you can take a screenshot. So this was a systematic review that was done in 2017 and a meta-analysis to balance out all the figures, and that's what was found. So the stuff we've been talking about with tendons is also true with arthritic knees and hips as well. So again, people are really worried about doing it because of the stories that they've heard, and it's the myths are still being perpetuated in the medical profession. So we need to get out there and start spreading this information instead. Okay, so that's slight aside to the tendons that we've been talking about. So yeah, we've got a net anabolic effect, which is when a load is applied and then you adapt to the load. And again, we went over that last week, so I'm not going to cover that in great detail. And then this net catabolic effect is the couch potato. So, and this is something you'll hear quite often. I didn't even do anything to aggravate it because I was resting, or I was told to rest, or I've rested for ages and it's still not any better. And this is why we have a change in collagen, we have a change in tenocytes, which is tendon cells, and the load-bearing capacity of the tendon is reduced. So then even low levels of activity can be detrimental. So if people have had a long layoff, we then need to introduce them back to activity and load in a very controlled manner. And again, quite often people will feel better, so they'll go and do what they were doing before they got injured or before they started feeling their symptoms, and that can be counterproductive. So yeah, we need to build those people back up again, and they're often really annoyed about that because they're so used to being fit and just going out for a run, and then they're told that they have to scale everything back. And but you can only give advice. You can lead them to the water, but it's up to them to drink it. And then this is from, let me just get rid of that. So this is from Cook and Purdon. We talked about this. So this is where we want to stay. We want to stay in this normal tendon where there's an adaptation to load and you get stronger. But if you're sedentary, then it can make you have a mechanically weaker tendon. And then normal or excessive loads can create a reactive tendinopathy. So you basically have symptoms. Or you can increase your load, so come down this area here, so excessive load and individual factors, we talked about that as well. And again, you can have a reactive tendinopathy. So whether you're sedentary or doing too much, it leads to the same place. So we need to modify the load and then get them back in this loop. Okay, so that's the plan. The only problem is no one has a clue what it is. So you have to do a really good case history because you want to get all of the information you can about their previous training history, whether they've just started and never really done anything before, or whether they've been running or lifting weights or whatever it is for years. So yeah, we want to get a good history because that will guide your starting point. Okay, so yeah, and then what we didn't cover was this. So we're going to have a look at another area that is where you have common tendinopathies, and that is in the hamstrings, and specifically the proximal hamstring, so the bit that attaches to your ischial tuberosity. So let's move me out away from that ischial tuberosity. Here we go. So we've got a at the proximal attachment. So this is your ischial tuberosity here. The hamstring has got specific attachment points, but this model, and you'll see the next picture as well, has been really cleaned up. So a lot of the connective tissue has been taken away to highlight the specific insertion points. Okay, so in terms of load, yes, you will have a specific area where a specific hamstring will attach to, but the load is distributed as well by the connective tissue, by the fascia. So it's take this with a pinch of salt, basically. Okay, so you can't say, oh, because your symptoms are here on the ischial tuberosity, that means it's your biceps femoris or whatever. Okay, it's impossible to say that, because look at how many things attach into a very specific area. Okay, so we've got semitendinosis, long head of biceps is attachment point 1, so around this area here. Semimembranosus is around 2, and then your quadratus femoris, which we looked at a few weeks ago on the rotator cuff of the hip, that's number 3 there. So I've done exactly the same image, but in complete anatomy, so you can see it a little bit easier. So semimembranosis, biceps femoris, semitendinosis, that's roughly where they will attach. Okay, so those are the attachment points. It can be useful, this, because semimembranosis is a little bit more lateral, and biceps femoris, semitendinosis is a bit more medial. So if you're doing directed treatment, things like shockwave or laser, whatever it is that you use, you can, if you can visualize their ischial tuberosity and try to aim towards those areas, then you're more likely to affect the attachment points of those muscles. But again, you can't be really specific, and you usually use symptoms as a guide anyway. Okay, so just to let you know. So here's another image where they've started to separate out the tendons. Okay, so I mean, you can see how closely they are linked. Okay, so they're basically all kind of merging, like I say, all merging together to each other anyway. So that's your proximal hamstrings. This is Tom Goom is really good for this kind of stuff. So he does a lot with tendon problems. Seth O'Neill as well is another good guy. If you've not heard of those guys before, worth having a look at them. So hamstring tendinopathy is characterized by buttock pain localized to the hamstring attachment with an area similar to 2 fingertips. So literally you can stick your thumb on it, okay, and it's right on the ischial tuberosity. But they will often complain of like sciatica type symptoms around that region, and like piriformis. If they've been Googling it, they'll often complain with that as well. So being specific with the ischial tuberosity is useful. Aggravated by hip flexion activities, because in hip flexion you're going to compress the tendon against the ischial tuberosity. So things like periods of sitting, again, where you're compressing it as well, driving, deep lunges, hamstring stretches. I mean, that's a key one. So if someone does think it's their hamstrings and then start stretching it, there is a thought, although it's debated, that can aggravate it too. And running at high speeds because of the position of the leg when you're sprinting. So all of those kind of things can aggravate a high hamstring tendinopathy. Usually a history of increased or unaccustomed load, so that's that imbalance. Yeah, so too much or not enough. So hill running, maybe they've started doing deadlifts or they've been excessively stretching. More than usual. Soreness in the morning is really key, and also soreness after rest. So if they've been sitting for a while and then they get up and it's like, oh, it really aches, but then once they get going it feels okay, that's classic tendinopathy. Okay, so those are usually the things that you will hear with a hamstring problem. And then lastly, yeah, so this is the hamstrings that are usually affected. So the common hamstring tendon, so that kind of the blob as a whole, if you like. Biceps femoris is your biggest issue usually. Then semimembranosis, then semitendinosis. Semitendinosis is very low. So it's usually either biceps or semimem. Proximal hamstring tendinopathy is considered to be an insertional tendinopathy. That insertion where the tendon attaches onto the bone is called an enthesis. Okay, let me just type that out for you. If you want to, it would help if I spell it right. So it's spelled like that, okay, an enthesis. So if you you may hear it called an enthesopathy. Okay, so an insertional tendinopathy, so where the tendon inserts, is sometimes called an enthesopathy as well, just to confuse things. Okay, so what else have we got? Yeah, so thought to be insertional tendinopathy and compression of the tendon at its attachment during hip flexion. Adduction is thought to be a key etiological factor. However, evidence supporting this theory is limited, as pathoanatomical studies of the proximal hamstring tendons are sparse. So basically, there's just not enough research around it to prove it either way. Further research is required to better define the nature and degree of tendon compression in functional activities. So that's why I was saying about the stretching thing. So stretching could aggravate it, but it may not. Okay, so it's one of those. If it isn't, then carry on. Okay, yeah, you just have to if you think it's a valuable thing to do. Cool. So that wraps up tendinopathies for gluteal region and the hamstring, and those are the kind of main muscle pathologies that you'll see around that kind of area, other than obviously like muscle tears and things like that. Can happen in any of the muscles. So usually it's the biarticular ones though. So let's go back to where's that gone? Oh, I think I've put it on the wrong slide. Let me have a look. If I put it here, no. Bear with me a sec. Just try and find my slides. Oh, I don't think they're there. No. Bear with me a second. Let me just put those on. Talk amongst yourselves. Here we go. South law, it's not on that one. Bear with me a second. Hip and pelvis. Nerves. There we go. Pop it on there. Cool. Okay. Just move it down to there. There we go. Perfect. Right. So this is a bit of a chunky one. And it may take a couple of goes. So next week is a bank holiday, so it will give you a chance to watch it twice, which is good. So yeah, nerves of the hip and pelvis is there's a lot to cover. Okay, so I'm gonna do it as if no one's ever covered nerves before, and do you know what? When people say that, I'm like, thank God for that, because I'm hoping that you don't assume I have any knowledge of anything. Okay, so what we've got are three key branches of nerves, and you may have heard of this if you've been doing these for a while. So we've got motor branches, which supply the muscles, and that is called an innervation, not innovation, but innervation. So if you hear of nerves innervating muscles, that means that's the nerve that goes to the muscle and turns it on, basically. Okay, so those are motor branches. And when we get up into the spine area, we'll do a whole section on the discs and everything, and where the nerves come from. Then we've got sensory nerves, and these are often forgotten nerves. These are nerves that are cutaneous, so they're in the skin, and they provide sensation from or to the skin from the skin. So you receive touch sensation on your skin via the cutaneous nerves into your central nervous system. Okay. Then we've got articular branches, and these are sensation from the joints. So it could be the capsules, ligaments, synovial membrane. So we've got various branches from the main nerves that go off into different areas of the region, and they have different jobs. So some will turn on muscles, some will receive information from the skin, and some will receive information from your joints. Okay, and then all of that is all going on all at the same time. And then from all that information coming into your central nervous system, your brain then makes sense of your world. Okay, so that's what we're dealing with this particular region. So the first one we're going to have a look at is your femoral nerve, and we've got a couple of different divisions of the femoral nerve. When we look at the lumbar spine, we'll look at where it comes from. So L2 to L4 relates to the lumbar spine region where the femoral nerve arises. Okay, so from those nerve roots. And then those nerve roots then form together to form one nerve, and then it will branch off into different bits. Okay, so the first thing that happens is we've got an anterior and posterior division of the nerve. So we've got a part of the nerve that stays towards the surface, towards the front of the body, and then part of the nerve that dives down and goes posteriorly. Okay, so a bit more towards the back. So if we have a look at this, we've got in the anterior division, we've got two motor branches and two sensory. So the motor branches of the femoral nerve and the anterior motor branches supply the pectineus muscle. If you remember, we were talking about that a couple of weeks ago. So that's one of your inner thigh muscles, and also your sartorius muscle. So the big one that goes all the way across down to the knee. Okay, so those are the muscles that this particular division of the femoral nerve supply. Then we've got sensory branches. So these are branches that supply the skin. Okay, so we've got medial cutaneous nerve. So this is basically it's translated as the midline skin nerve. Okay, so that's what that means. And then we've got an intermediate cutaneous nerve in between skin nerve, and you'll see why in a second. We've got different cutaneous nerves that supply the outside of the thigh, and they're not related to the femoral nerve. Okay, so sometimes that can be a bit confusing. So the femoral nerve will supply the skin sensation to your inner thigh and over kind of rectus femoris area. We'll have a look at a picture in a second. And then the posterior division, this has got 4 motor branches, so it supplies 4 different muscles, and then 1 sensory branch and 2 articular branches. Okay, so it's a bit busier, this one. So the motor branches are to rectus femoris, so your main kind of front, most superficial quad muscle. Then we've got vastus lateralis, vastus medialis, and vastus intermedius, but also a little muscle called articularis genu, which is the one that lifts the synovial pouch. Okay, so when you're extending your knee, it lifts the pouch out of the way so that your patella can move a bit easier. Okay, it sits underneath your vastus intermedius. Then we've got a sensory branch that is the saphenous nerve, and this goes way away from where all this lot goes. Okay, so we'll have a look at that picture in a sec. And then the articular branches are to the hip and the knee. Okay, so this posterior division supplies the nerve so that you can get sensation from the hip joint and the knee joint. Okay, so the synovial fluid, the synovial membrane, the capsule, all of that is supplied by this posterior division. Okay, cool. So it's a bit busier than you think, or I initially thought. Anyway, so this is a really nice picture because it shows where it comes from and then the extent of the reach of the femoral nerve. So nerve roots L2 to L4. Okay, and again we'll cover those when we get to the lumbar spine. Then they all join together. So this is called a plexus, and then they join together to form a single nerve. But actually, there's still several nerves. They're just all wrapped up in one bundle. Okay. Then we've got this little branch here that goes off to the iliacus. Okay, this is before it goes into the divisions, and then your nerve to the pectineus. Okay, just there. Then we've got so that's part of the anterior division just here. Then the posterior division branches off this way, and it's separated by an artery. So we'll have a look at that artery when we come to do that in a second. So this is the artery, so the lateral circumflex femoral artery. So where the main femoral artery comes down, there's a branch that comes off and it supplies the hip joint. And the nerve is split around that artery, okay? And that's how it's divided into anterior and posterior divisions. So the anterior division here is coming down to sartorius as well, which we said before, so pectineus and sartorius. And then we've got these branches here. Now, this one will be motor. This one will be motor, because they're both going towards a muscle. And then these ones will be receiving information. So these ones are sensory nerves, so cutaneous nerves coming back from the skin, okay? So they all look yellow on the pictures, but and you wouldn't be able to tell by looking at them which ones are which. But we know that there are specific nerves that receive information, specific nerves that send it, and then some that are mixed at various points, okay? So if we have a look up here, like that bit there, that will be mixed, because we're going to have sensory information coming back this way, up through there, and into whichever branch it goes through. Then we've got motor coming from this region here and then down towards pectineus. So that area there is going to be mixed, yeah? And it's all bundled together, and it will be going both ways. And we won't be able to tell, like I said, just by looking. Then we've got this posterior division, so that tucks behind that artery, and then that goes into the hip joint, so a little branch off there. So this one will be mixed as well up to this point, and then it will go sensory coming back, because that one specifically goes to the hip joint. And then this one comes off and goes rectus femoris, yeah? And then we've got these branches here for the quads, and then that one there going off to the knee joint, which again is a sensory nerve for the articular branch for the knee. There's an infrapatellar branch. We'll cover this, we'll covered it on the knee section. But this is the interesting thing. So once it gets past the knee joint, it then continues as the saphenous nerve, and that's purely sensory. Okay, so we've got the infrapatellar branch coming up around the knee, or inferior to the patella, to the skin on the medial side of the leg. So that's the inside of your shin. Okay, so the saphenous nerve covers all that. And then the skin on the medial side of the foot, up to the ball of the great toe. So all the way down your foot. So all of that from there, that point there, all the way down, that is all sensory. Yeah. So can you see how it's a bit of a mixture? So we've got motor coming off, supplying the muscles, the articular branches going off and receiving information from the joints, and then the cutaneous branches going off and receiving information from the skin. Okay, so all of that is happening within the same femoral nerve. Okay, so let's have a look what it looks like. Get rid of that one and that one, pop that one on. Hopefully this is it. Soon find out. Yep, cool. Okay. Shrink me down. Okay, right. I'm just going to pause that there. Okay, so a bit of an orientation then. So this is looking at the front of a, they've chopped off the right side, the left side. So this is the front of a right pelvis and the right thigh. Okay, so if I just grab my arrow there, so there's your ASIS, that's your iliac crest all the way around there, that's your lumbar vertebra, and that piece of connective tissue there is the inguinal ligament, and we talked about that over the last couple of weeks. So muscles wise, so there's your iliacus muscle, be rectus femoris probably there, a bit of TFL as well potentially, and then your adductor muscles around here. So those are the muscles that we've been covering over the last few weeks as well. Okay, so this is what we're interested in, is this nerve, and you can see that you can't tell. Let me just pause that there. Okay, you can't tell that you've got some sensory nerves, some motor nerves, some articular branches. You haven't got a clue, because it all looks exactly the same. Okay, it just looks like, and people who've watched me before will know, it looks a bit like calamaris. Okay, and it's quite tough as well. There is a bit of give in it, but it's pretty tough stuff, and they're quite big as well. They're a lot thicker than you imagine nerves to be. I mean, your sciatic nerve is like the thickness of your thumb. It's huge. So yeah, these are pretty big structures. So the femoral nerve is on the outside there, around there. See that one there? That's your psoas, which we looked at last week, I think, and then the obturator nerve just there. Okay, so they're all going off in different directions, and they're called the names they are because of where they go. So the femoral nerve is obviously the femur nerve. The obturator nerve goes through the obturator foramen. So that, and remember, obturator means to close. So the obturator nerve is involved in the adduction movement. Okay, so the adductors, and we'll cover that when we get to it. Okay, so that's your femoral nerve that we're interested in, just here. So it's coming from L2 to L4 from the lumbar vertebra, and again we'll cover those in a bit more detail when we get to the lumbars and how the nerves emerge, because they split again up in there as well. That bit there, I don't know whether you can see those, but that's your sciatic nerve just there as well. There's your iliacus. This is the femoral. So it goes underneath the inguinal ligament, just here, and then you can see that there. It's now starting to split. There we go. Okay, so this is exactly what it looks like. So if I just pause that there. So can you see these little branches coming off here, and then they just rest on the surface of the muscle? Another one there, another one there. Yeah, that's basically the attachment. That's what it looks like in real life. So it's literally just kind of weaves into a point in the muscle, and then that's it. That's where it controls it from. No problem, Martin. Are nerves hard to cut through? Not really. Not with not with a sharp enough scalpel. You can. The cutaneous nerves are really easy to go through, and because they're really fine. See, what we would try to do with any kind of dissection work is not use the scalpel too much, because we want to preserve as much of the tissue as possible. So we tend to use what's called blunt dissection, which is basically using your hands or using your fingers, and kind of because everything's got loads of connective tissue, loads of fascia. So you just try to work away that fascia. And we were talking about that the other day, actually, about how anatomists can create any shapes they want. So you look at the anatomy trains, and it can be anybody can create any kind of anatomy train. You can do whatever you want with it, and then just take a photo of it and go, yeah, this is the, I don't know, functional front line instead of functional back line. And it's very easy to do. Very easy to do that. You just cut it in a different direction. But generally we will use blunt dissection because we don't want to cut through the tissue, because the skin is really, really thin. And if you're trying to have a look at the cutaneous nerves, you'll just go straight through them if you don't pay attention, basically. But yeah, so cutaneous nerves are easy to cut, definitely. The bigger nerves, like the femoral nerve, when it was a little bit higher up there, it's going to be a bit tougher, but it's not hard. So the femoral nerve supplies all your quads, your pectineus, so the inner thigh muscle just there, and then the sartorius, which is the big muscle that goes across. So that one just there, which was there, just go back, which is that one there. Okay. A friend of mine, when we were doing our anatomy dissections together at uni, she was having a look at the number of attachment points of the sciatic nerve into various different muscles, and then she was mapping them out on the muscles. So that was quite cool. So you can see the variation in how many synapses there are in each of the muscles. So it's it varies from person to person and from leg to leg as well. Okay, so Yeah, the femoral nerve is in the anterior compartment, and if you remember that from a few weeks ago, we talked about the thigh being like the wheel on a Trivial Pursuit board, but instead of it having 6 cheese wedges, it's only got 3. And we've got one at the front, which is the anterior compartment, and then the sides of the wedge come down. So there's a really strong fascial connection to the femur. Then we've got a medial wedge and we've got a posterior wedge. Okay, so the femoral nerve is in the anterior compartment. Okay, that's where it resides. Do they reconnect after an operation? I still have numbness in my glutes 7 years on. Unfortunately, if it's 7 years on, I would say that the chances of it coming back are quite slim. Usually it will come back after about sort of a year, 18 months if it's going to. If it's been severed completely, then unless they've tried to reconnect it, then unfortunately not. In my experience, okay, there may be new technology, I don't know, but yeah, I think if you've had it for that long, then I think you'll struggle to get it back, unfortunately. This is the sensory distribution for the femoral nerve. So remember we were talking about those cutaneous nerves, yeah? So the anterior femoral cutaneous, okay, so the branch of the femoral nerve. So we've got this one here. So there was a medial cutaneous and an intermediate one, yeah? So that's what these branches are here. So this is the front of a right leg. And then have a look here. This is your saphenous nerve, okay? So this was, if we go back, there, okay, so that was this one. So that's the saphenous there. So that goes down to the leg and foot. And then let's have a look. Yeah, here we go. So medial cutaneous and intermediate cutaneous. So those ones are going to supply the front of the thigh. So let's have a look at that again. So that's the medial and the intermediate ones. And then that's the saphenous. Yeah. So the different branches will go off and supply different parts of the skin. So if someone is losing sensation on the inside of their thigh, inside of their leg, okay, so around their shin, that's likely to do with the femoral nerve, okay, and it could be anywhere along the pathway. So it can be at the nerve root, or it could be somewhere along where the saphenous nerve runs, okay. So yeah, that's that one, and then we'll just start the obturator, okay, and then we'll call it a day because we've done quite a bit already. So obturator then. Talk about obturator to close, okay, so that's what it's involved in. Excuse me. And this is the obturator foramen, which we looked at when we were looking at the Bode landmarks. And here's the obturator nerve just there. And what it does, there's a little gap in the foramen. It's like a little purpose-built hole for the nerve to pass through, okay, and then that nerve then splits into 2 as well. So we've got a posterior and anterior branch of the obturator nerve as well, okay. So this is on the kind of inside of the pelvis area. Let's have a look then. So we've got anterior and posterior divisions again. The anterior division has got 4 motor, 1 sensory and 1 articular branch. So we've got a motor branch to pectineus. So it's got 2 supplies, pectineus, adductor brevis, adductor longus, and gracilis. So these are all adductor muscles. Okay, so they're the ones that are going to close the legs. Okay, and then the sensory part of the nerve is where's the articular branch gone on that? So the sensory part of the nerve is the obturator cutaneous nerve. In fact, that one, I don't think that one has an articular branch. I will check. I'm pretty sure it doesn't, unless it goes off to. No, that's posterior branch. Yeah, I think that's wrong. So let me check and I'll get that updated next week. So the sensory branch is the obturator cutaneous nerve. So that's going to be sensation to the inner thigh. Then posterior, 2 motor and 1 articular branch. And the articular branch, just move me out of the way, whoop, is to the knee. Okay, so the obturator nerve will supply the sensation to the knee, and then also obturator externus and adductor magnus. Okay, so again, a big adductor muscle and then a rotator muscle, so a small hip rotator as well. So those are the divisions. Let's have a look at this. Yeah, here we go. This will let's have a look. Yeah. That's it. Yeah, so there is an articular twig to the hip joint. So if we just go back to that previous slide. So on the, I thought it was that one there. Yeah. So we've got that one there, which is the going off to the hip. So it's just missed off the list. That's all. So articular branch to the hip on this anterior division, and then articular branch to the knee on the posterior. Okay. Let's go forward again. There we go. So posterior division here is going obturator, adductor magnus, and then through the adductor hiatus, which we looked at a couple of sessions ago when we looked at the pathway of the femoral artery. Okay. Then we've got most of the adductor muscles. Okay, so pectineus, adductor brevis, adductor longus, gracilis, and then through to supply the skin on the medial aspect of the thigh. Okay, so the sensory distribution is there, is that area there. Okay, so remember the femoral nerve was around here, so that, and there will be some overlap. So the femoral nerve is the medial part of the front of the thigh and the intermediate part of the front of the thigh, and then the obturator supplies the skin on your inner thigh. Okay, so if you have a loss of sensation there, then it's usually to do with the obturator nerve. Okay, cool. Right, I think. Oh, some of my controls have gone missing. That's a bit weird. Are we still? Yeah, we're back on. Cool. That was a bit strange. All of my stuff just disappeared. So we will leave it there, and I will we'll have a look. Just get rid of that arrow there. We'll have a look at the obturator nerve video next week. So we'll show you that. Not next week, week after. So if you want to go over this video a couple of times, then you can do a bit of a catch up like Martin's done over after missing the last session. And I'll be back the week after half term, not half term, can tell I'm tired. After bank holiday. Okay, so after bank holiday, I'll be back, and yeah, less snotty and bunged up. I will see you in 2 weeks. Have a look at that obturator nerve, and yeah, we'll catch you then. See ya.